the MLA for Yellowknife North and chair of this committee. Today's meeting we will have a public briefing from the officials of the Office of the Auditor General. I would like to welcome Ms. Casey Thomas, the Assistant Auditor General, Maria Pooley, Audit Director, and Joanna Schwartz, the Principal of this performance audit. Before we begin, I will ask committee members to introduce themselves, beginning on my left.
Thank you, Mr. Chair. Caitlin Cleveland, MLA Cam Lake.
Katrina Knockleby, MLA Great Slave.
Lisa Semler, MLA for Nuvik Twin Lakes.
Thank you very much. Before we start, I would like to remind members and witnesses that all comments, questions, and remarks need to be directed through myself as chair, and please wait to be recognized before speaking. We are also joined today by Committee Advisor Nigel Woolwork, Committee Clerk Cynthia James, and Committee Intern Taylor Maxwell. With that, Ms. Thomas, I will turn it over to you to introduce your staff and any opening remarks.
Great, thank you, Mr. Chair. Mr. Chair, thank you for this opportunity to discuss our report on addictions prevention and recovery services in the Northwest Territories, which was tabled in the Legislative Assembly on May 31st of this year. I want to acknowledge that we are gathered on the traditional unceded territory of the Yellowknives Dene First Nation. With me are my colleagues Joanne Schwartz and Maria Pooley, who were responsible for the audit. In this audit, we wanted to know whether the Department of Health and Social Services, the Northwest Territories Health and Social Services Authority, the Hay River Health and Social Services Authority, and the Cleetcho Community Services Agency provided addiction services to meet the needs of Northwest Territories residents. Addiction services are important because they have a far-reaching impact on the lives and well-being of individuals, families, and members of the broader community. This importance is amplified in the Northwest Territories because the territory has a high rate of substance use. We found that the department and the 3 health authorities had taken steps to address their long-standing commitments to improve addictions services. However, there is still much work to do to provide residents with accessible, coordinated, and culturally safe addictions services. For example, the department and the 3 health authorities had committed to providing equitable access to addiction services for all residents across the territory. However, they had still not figured out how to achieve this outcome. As a result, services may not have been available to residents when they tried to access them. We also found that the department and the 3 health authorities did not do enough to ensure that addictions services were culturally safe for Indigenous residents. Given the legacy of colonization, culturally safe services are critical to facilitating equitable access for these residents. In addition, we found that aftercare services were limited. In the cases we looked at, many individuals who attended a treatment program in a facility did not get the aftercare services they needed to support their recovery goals once their treatment programs ended and they returned to their communities. We also found that gaps remained in the coordination of addiction services, even though the department committed 20 years ago to better coordinating the health and social services system to improve access. Coordination is important because various organizations provide addiction services and because individuals can enter the system at different points. The system needs to be well coordinated to help individuals move through it to get the services they need. Lastly, we found that neither the department nor the 3 health authorities knew whether their addictions services were effective in helping residents achieve their desired outcomes. We found that residents' outcomes were insufficiently measured and that data was not used to analyze trends to improve services. The Department of Health and Social Services and the 3 health authorities have agreed with all of our recommendations and have prepared an action plan to address them. We have reviewed the action plan and feel it outlines initial steps to help address our recommendations. Mr. Chair, this concludes my opening statement. We would be pleased to answer the committee's questions. Thank you.
Thank you very much, Ms. Thomas, for your presentation and all of the work that your office does. With that, I will open the floor to questions or comments from committee, beginning with MLA Semler.
Yes, thank you, Mr. Chair. I've asked this question, so my question around culturally relevant care, I know I've raised this before, is, you know, when we say culturally relevant care, and you're saying that the department hasn't done this, how, when we know that there's so many different cultures in the Northwest Territories and the expectation of the Northwest Territories to have a policy to do this, how is it that you measured this? And I'll probably have these same questions for the department when we have them as witnesses. Thank you.
Turn it over to you, Ms. Schwartz.
Thank you, Mr. Chair. Thank you for the question. So as part of the audit, we did determine that the department hadn't done enough to ensure that the services were culturally safe. And that's something that the department has, made recommendations about, and the department has committed to work on. From our perspective, you know, that's very important in terms of people being able to access the services they need, is to feel safe. In terms of how to measure that, I think that, you know, we have to take a step back and acknowledge that it's not for us to say how it could be measured. Cultural safety is an outcome of how an Indigenous person feels, that they feel that they can access services in a safe environment free of racism and discrimination. So from that perspective, the department should be thinking about how they can ensure that the services and programs are culturally safe. That could include asking residents how they feel that they can get services in a safe manner. And in addition, trying to figure out how you could ask people who are not currently using the system, why they're not using the system, and seeing if it has anything to do with their feelings of safety, and then working to address that. I'll see if either of my colleagues have anything to add.
Ms. Pooley?
Mr. Chair, I would just add that another important factor could be trying to find Indigenous measures of outcomes and not to solely rely on what we might consider to be Southern or Western or whatever the right terminology would be, outcomes, because they might themselves have different yardsticks, I guess, that would indicate success in that area. Thank you, Mr. Chair.
Thank you. Any follow-up, MLA Semler?
Thank you. Thank you for that answer. I mean, it just goes to show that it's not as easy and clear as it's like we can throw these terms around. And one thing that I know that we've asked the government on culturally relevant care, and you know, I think a lot of people have made comments. I mean, you can look at a lot of member statements in the House on addictions and mental health issues. Right now we're having a crisis in the Beaufort Delta. It was even in the new statistics, like there's the highest rate of suicide going on, and people are saying that there's a gap because the services that the minister and their departments keep saying that is there is not meeting the needs of those. So I guess my question would be to how would you, like with whatever the GNWT has come back to you with how they're going to deal with that, do you feel that that's enough? Or is like, I mean, because when we look at some of the stuff that the responses, it's a plan of a plan, but we have people dying and we have addictions and we have our people, like 50% of the people in Northwest Territories are Indigenous. And when we look at the statistics, majority of the people that are struggling, even though the report says that we're not really counting who, like they're not tracking whether they're Indigenous or not Indigenous, we know that these are the ones that are suffering. So like what, like, do you agree with how they're responding to the recommendations from your report?
Ms. Thomas?
Thank you very much for the question, and again, I'll start and then pass it over to my colleagues to see if they have anything to add. With respect to the department's responses to our recommendations, I would say that they are a good start. However, in looking at their timelines and their actions, I think it's important to understand a little bit more about the details and how those details will improve services, improve access, and improve outcomes. And I think once a few more details are understood, then the timelines themselves will become clearer, and an assessment of reasonableness can be looked at from that perspective. And I'll ask my colleagues if they have anything to add.
Ms. Poole?
I would also just add that part of it would be, I mean, in theory, everybody has access to a counselor in the territory that's free of charge. I think some of the work could relate to our finding about the Indigenous qualifications, or the qualifications that aren't, again, that Western style. And the department has recognized that a best practice for cultural safety is to have a diverse workforce that reflects the population that it serves. As you've stated, that would be a lot of Indigenous workers in the system. And part of what we looked for was efforts for the department to try and find ways to get Indigenous people into the system. They are not tracking the use of certain programs that are in place from the Department of Finance, and also they hadn't started any work to try and find other ways to recognize skills that could help people that aren't necessarily that clinically based model that comes through higher education, that we know also from our past audit work can be a challenge for people in the Northwest Territories to access. Thank you, Mr. Chair.
Thank you, Ms. Poole. Next, I have Emily Knuckleby.
Thank you, Mr. Chair, and thank you for the presentation, the report, and your work. I have to say, while some of it is shocking, it's not a surprise to me that we are failing in this area, and quite dismally from what I'm reading between the lines. And you're a little more politer than I am, I guess, in saying that. Rather than spend my time telling and reiterating how bad the state of the addictions treatment in the territory is, the lack of aftercare, the lack of detox options, culturally relevant. I guess I'm curious to know more around like solutions and things that we can do. I feel that we're not great up here in the territory about coming up always with our own solutions, and often we don't have capacity for that. So I guess I'm looking to see about adopting other solutions. And I know that we had spoke about the SDG standards, the UN standards. Maybe could the auditor speak a little bit about those standards and how they maybe could make our services more accessible or more equitable for our residents? Thank you, Mr. Chair.
Thank you. Over to you, Ms. Thomas.
Thank you, Mr. Chair, for that question. I'll start off by saying that the Office of the Auditor General has made a commitment to ensure that all of our work incorporates the Sustainable Development Goals, and we have a Sustainable Development Strategy that outlines our work and what we do and how we do it. And we would typically go in and do that work in all jurisdictions. In this case, the GNWT has not formally adopted the SDGs, and as I think would have to be done is this would be a policy decision by the government. The SDGs are not something that we would, while we would look at them in each audit, we wouldn't necessarily recommend in the course of one audit that the SDGs be adopted. This being said, during our audit work, we did find that our work linked directly with and aligned with goal number 3, which is around good health and well-being. And in fact, the department had already incorporated into its own work 2 of the indicators, which were around harmful use of alcohol and prevalence of tobacco use. And so I would say that that's a good sign. That's a step in the right direction, that even though the territory hasn't signed on, they're already thinking in that direction. And I think the piece I would end with is that, again, to loop it back, it would be a policy decision that the government would have to be made, but it would align with the philosophy that we've seen a little bit of in this audit.
Thank you. Any follow-up, Emily Knuckleby?
Yep, thank you for that. And obviously then that's something that we can take back as a committee and push for on our end. My next question is just around, as I know that there is a very specific scope of work for an audit, and that you come in and only look at the documentation around that. In doing so, were there other areas that you identified within the GNWT, within Health and Social Services, that you felt needed to or could benefit from an audit in the future so that we could improve our processes? Thank you, Mr. Chair.
Thank you. Over to you, Ms. Schwartz.
Thank you, Mr. Chair. Thank you for the question. So as you mentioned, the scope of this performance audit was focused on addiction services. And I can say that as part of this audit, we haven't identified another audit that we would be taking on related to any issues we uncovered in terms of health and social services. That said, as the Auditor General of Canada, when we come and do work and meet with different parties and meet with yourselves, we're always doing our ongoing strategic planning to identify future audit topics. So it's something that we're always interested in. If people who want to meet with us have other ideas about risks that they see that they might want us to pursue, including yourself, we can definitely talk about that. And I think one thing to keep in mind is that while our recommendations are focused on issues specific to addictions, like equitable access, measuring outcomes, and coordination, those are themes that could apply to other topics within health and social services, although this audit isn't focused on them. So we look forward to, conversing with you in the future if you have any suggestions for future audits for us to consider. Thank you.
Thank you. I don't want to speak on behalf of the committee, but I think housing's a priority. We all look very closely at the Yukon's housing audit, and we also know that the Health Authority and Health and Social Services has been subject to a number of audits, so that there is some work to make sure we're implementing the action plans as opposed to keeping them endlessly in a cycle of audits. With that, I'll turn it over to MLA Cleveland.
Thank you very much, Mr. Chair. Mr. Chair, I'd like to circle back to MLA Semler's questions around culturally safe services. One of the things that's very special about the Northwest Territories is we are so culturally rich. And we do have a lot of people in the territory who want to play a role in the success of the territory and want to be involved in the health of their communities. But what we often do is look elsewhere for examples of success. And so while we are trying to forge our own success in the territory, I'm wondering if the Office of the Auditor General does have some examples of health authorities that are leading the way with culturally safe services and also hiring practices. Thank you.
Who would like to take that? Ms. Schwartz?
Thank you, Mr. Chair. Thank you for the question. So while we don't have an example that we could readily point to in terms of best practice from a specific jurisdiction with regard to cultural safety being embedded in addiction services, I think that that's something that the department has recognized that they will be working on as part of their work plan and their action plan. And I think that that's an area where expertise could be sought from people within the health and social services system, either within NWT or across Canada, to give more insights into what best practices might be aside from our views. So with that, I'll just stop and see if my colleagues have anything they wanted to add.
Over to you, Emily Cleveland.
Thank you very much, Mr. Chair. I think that there's great opportunity here for the Northwest Territories to make a choice to be a leader in this one. My next question is also where an area that was seen as lacking within the report, and I think an area where, given that we are a territory of only but thankfully 45,000 people, there's an opportunity to make a difference here, and that's the issue of aftercare. And so I'm wondering if the Office of the Auditor General can speak to both what were the causes they found for the lack of supports within aftercare, and I'm also wondering if there is information that the Office of the Auditor General can provide in regards to the populations who are less likely to receive aftercare? Was it related to where people were located? Was it related to how they entered the system? And so I'm wondering if there's more information that can be provided on that. Thank you.
Ms. Schwartz?
Mr. Chair, thank you for the question. So as you pointed out, we did have findings related to a lack of aftercare services being provided for a sample of residents that we looked at who had sought and obtained facility-based treatment. So in terms of standards or requirements, the standards themselves are the requirements set out by the GNWT. So in our report, we have an exhibit that lists some requirements that the GNWT should be meeting. So they should have an aftercare plan, they should make sure that the services are offered, and they should try to make contact with the clients. So what we found is that even though the standards are in place for aftercare, they weren't being met for the sample that we examined. In terms of the causes for that, I think that that's something that would be best for the authorities to respond to in terms of why that occurred. Although we did hear as part of our audit, and we mentioned in paragraph 33, that at times the counselors weren't able to refer their clients to services because the services just weren't available. But I think the department and the health authorities would be able to give you some more information on the causes of why they didn't meet their own requirements. In terms of your question on whether the results were better or worse depending on the location, I think in Exhibit 2, I mean, we've broken it down by the different health authorities in terms of what the numbers show, and basically overall the results weren't positive regardless of what health authority we were focused on for our sample of files. I think that I'll see if my colleagues have anything to add.
Ms. Thomas, go ahead.
Sorry. Go on. So just to complement what Ms. Schwartz said in terms of what we found, I think this is an example as well that links to measuring of outcomes and measuring, gathering information in order to be able to make decisions, whether that be around equitable access, whether that be around aftercare plans, to really be able to identify where the needs are, where the challenges are, and where actions need to be taken and maybe resources need to be applied.
Thank you, Ms. Thomas. Any follow-up, Emily Cleveland?
Another one, absolutely. Thank you very much, Mr. Chair. I want to switch now to, there was some lines in the report in regards to digitizing client information and the data from the department. And I'm wondering if the Office of the Auditor General can speak a little to that and the impact that that had on their overall audit. Thank you.
Who would like to take that one? Thank you. Go ahead, Ms. Pooley.
Thank you, Mr. Chair. In the line in our report that I think you're referring to is in paragraph 61, where we talk about the paper-based files for the community counseling program. So in terms of the impact on our audit, it made it more difficult for us to access the files, as I'm sure you can imagine, particularly during the COVID-19 pandemic. Typically, we would travel to communities or regions or wherever the information is, but that wasn't an option when we were doing this work. That said, we had very good cooperation from the health authorities, and they did find a way with us. They worked very closely to find a way to scan them and send the information that we requested. In terms of the impact on the service themselves or anything like that, that's not an area that we delved into. It purely was just us trying to get at the access to the files. So I'm not sure if that answers your question in full, but I'll leave it there to see if it does. Thank you.
Thank you. Any expansion, Ms. Thomas?
Yes. Your Chair, I think what I would add is that paper-based files do not preclude data analysis. I think that's an important point to make, that just because the files were paper doesn't mean that work can't be done. I think there are other solutions that could be considered. I think sometimes when we're talking about data, we automatically think about sophisticated data software systems. In some of what the team looked at, I think there was a recognition that maybe some other tools, maybe even using Excel, could be used as a start to gather some information, put it into an Excel spreadsheet, and then do the data analysis from there. And I think what I'm referring to there is there would be two ideas there. One, paper file transferred into an Excel spreadsheet, or equally information directly put into an Excel spreadsheet, taking in mind confidentiality and the other areas that of course need to be taken care of. But I think it's an important point to recognize that paper files shouldn't mean that data analysis cannot occur. It's challenging, but it's still possible.
Thank you. Emily Simler, any questions?
Thank you, Mr. Chair. Going back to limited aftercare supports, I know when we've raised this with the minister in the House, and one of the things that she's come back with is on the land programs, and I know in the report, and I know the minister has also stated it, that they've increased the on the land funding available to Indigenous governments to 1.8 million, and then, but there was $624,000 that lapsed. And one of the things that this, I don't know if it's this committee, we continue to say within the government in the Northwest Territories is that it's easy for the government to say, okay, we'll put this pot of money for the Indigenous governments, this much money for Indigenous governments, but some of the Indigenous governments are taking that, and like I know that in my region, they're utilizing the funding, but then there are Indigenous groups that do not have the capacity. Like IRC and GTC are well-established land claim groups for almost 30 plus years. They are well-established, they have staff that could do this. But then when you look at a smaller community, say, down in the South HO, where they don't have a land claim, and they're still fighting that, they may not have the capacity to have somebody to write these proposals. And so we've talked to the government, like even EIA, to say, how can you create a position that can help Indigenous governments or people that want to access these dollars? Because not everybody, people can run the programs, but they just may not be able to access the dollars through the process. So did you review the program's administration requirements, and were they overly onerous or anything like that that may be like inhibiting people to accessing these dollars? So hence there's $624,000 not used.
Thank you. Ms. Schwartz?
Good question. So in terms of the on the land program, we did not do a review of the administrative requirements, but as part of our audit, when we spoke with some Indigenous groups, they did mention that the administrative requirements were burdensome, or it made accessing the fund difficult. So what we did then was look at, okay, well, what did that mean? And it did, as you can see in the report, mean that there was money left on the table, a significant amount of money left on the table in a fiscal year. So we didn't audit that specific program in terms of its effectiveness or how it was managed, but we did observe that we heard that there was some challenges accessing the fund, but then we did see that there was money left on the table. So we thought it was worth noting in our report as an observation.
Thank you. Ms. Pooley?
Thank you, Mr. Chair. I would just add that you can totally draw the link between this and cultural safety and the policy review that was committed to in 2016. Part of a policy review of the full suite of health and social services policies wouldn't, I don't think, just be about, how healthcare services are delivered by the authorities, for example. But it could incorporate all of the policies related to the programs to see if they themselves are adding barriers to Indigenous people or groups. So I would suggest that that could be an area that could be looked at through the policy review that we've recommended they undertake as they committed, 6 years ago. Thank you, Mr. Chair.
Thank you, Ms. Pooley. Next I have Emily Knockleby.
Give her 3.
Got all the time in the world. Go ahead, Emily Simler.
Thank you for kind of confirming that, because as in the past I've worked in and kind of had to report on government funding in previous jobs. So I knew that that was one of the things that we had struggled with, because we get funding from federal government, which the reporting is like a page or so, and here's our budget, this is what we spent our money on, and it met the needs, and then we have to report on the government funding, or even application for government funding, and you're, so, like, yeah, it seemed more complicated. And it could be a deterrent, especially if you don't have the dedicated staff to be able to do those things. So I'm glad that came from the report. My other kind of question is around this gap in service, and I know that I raised this before, because there's this gap where we have the aftercare, and even going to treatment or accessing care. So I know that in the report, they had their gaps in process, because the staff in the health and social services, they're hired, and this is where it goes to that hiring thing, is not always are they educated and trained to know when they come into this community and they're hired through the GNWT as a community counselor. Do they know that they have all these other counseling programs through the Indigenous government? And so when I was working for an Indigenous government, they had a very strong counseling program through the federal program, and we were assisting those clients to go to treatment as well. So, and then coming back and then trying to collaborate with health and social services there was always this, you're always trying to figure out who does what and how do we work together. And so one of the kind of the question would be is, were you able to, during this process, figure out how many clients kind of fell through because of where they accessed the services? And I know my colleague kind of, but my concern is they're coming in, and then it's like, well, who's responsible when they come back? Like, if I can get them out, great. Or if health and social services can get them out, great. But who's meeting them at that airport when they're coming back? Who's doing their aftercare? Who set that up, and who's arranging it? And so that's what we're lacking, and then our people are falling back into their addictions and homelessness again. So I'm just wondering, again, like, was there anywhere that you measured that, and were the numbers significant?
Ms. Schwartz?
Mr. Chair, thank you for the question. So as part of our audit, we did look at coordination and how clients would find their way to the services that they needed to or they wanted to obtain. And we did find that there were gaps in terms of the service providers being able to direct the clients to where they needed to go. So definitely we saw a gap there, but in terms of measuring how many people fell through those gaps or that kind of measure, we didn't do that work. We did make a recommendation that there should be some formalized processes to help connect clients to the services they need, but our audit work didn't include a measurement of how many people didn't find their way to the services that they wanted to obtain.
Ms. Pooley?
Thank you, Mr. Chair. And I can just add a bit more detail about the work that we did do. So as you noted, Ms. Semler, there are other means by which people can go to those facility-based treatment programs. We only audited the people or files of people who had gone through the CCP program that is run by the authorities, because we don't have the mandate to audit the Indigenous governments or the other NGOs, for example, that can also refer people. So just to add that note there, that we don't really know in terms of people coming back from other referrals. When people who are referred through the counseling program come back, they are supposed to be coming back into the care of the case manager who referred them, is our understanding. So, but for other organizations, I'm afraid we don't have that information. Thank you, Mr. Chair.
Thank you. I've just been informed that we have simultaneous interpretation happening for our broadcast, but their audio is cutting out. So we're going to take 5 to sort out some technical issues, everybody. Thank you. I will call this meeting of the Standing Committee on Government Operations back to order. Thank you. Next on the list, I actually forget, Emily Knockleby.
Thank you, Mr. Chair. I'm an engineer by training, so I love data and I love like outcomes and measurements and all of that. And I have really found as I've learned more in this role that we're not great as a government about setting targets for ourselves and then, striving to achieve them. Part of that, I think, is because if you set a target, then you have to answer for why you don't meet it. So I do think that is a problem in our government. It's hard to deal with problems if you don't actually fulsomely characterize what the problem is. So part of that then is to have, something for people to strive for. So I guess I'm looking at the outcome indicators and what your audit showed us about that. Noting that you had said that in 2021, it was the first time that Health and Social Services assessed client satisfaction with a survey. I even have issue with the surveys as a method necessarily because, as you mentioned, it doesn't capture the people that are not participating in the surveys. So, and often when you're disgruntled, you tend to be less participatory than you would be otherwise. So I guess could the auditors maybe speak to why there weren't any outcome indicators established, and maybe if there were some method that they could recommend for us to implement to start tracking those types of outcomes. Thank you.
Thank you. Ms. Schwartz?
Thank you, Mr. Chair. Thank you for the question. So we did find as part of our audit that the department did not establish outcome indicators for most of its services, but it did for some. So in terms of looking forward, it means that it can be done. So while they didn't do it for most of them, the fact that we saw that it was done for some is an indication that it's possible. And then in terms of measuring those outcomes, so first is establishing them, then is measuring them. Before 2021, you're right that the department only measured outcomes for 2 of its services, one being the community counseling program. And that was a survey, and they were asking about satisfaction, as you mentioned. So in terms of setting the outcomes and measuring them, we definitely noted that more work could be done in that area. Because at the end of the day, if the department doesn't sit back and get a sense of what the outcomes are people wanted to set for themselves and whether they're being achieved, then they don't really know if the programs that are in place and the services that are in place are actually helping people. So we definitely encourage the department to work on that area more.
Go ahead, Ms. Thomas.
Thank you very much, Mr. Chair. I would amplify Ms. Schwartz's point about it's the department that needs to understand its needs, set the targets, collect the information, and then make changes as required. And I think I want to also, Mr. Chair, go to a point that was also brought up, which was around who do you collect the information from. And so obviously when you have individuals who are filling in surveys or filling in information, those are one source. That is one source. I think it's also important to pursue other sources. We've talked about the possibility of those who are not accessing the services to understand, what the barriers are, why they may not be accessing, and what they may not be able to access. I think it would also be important to reach out to the healthcare providers and the other individuals in the system to gather information and data from them, and looking at both the qualitative, possibly anecdotal, I'll use that word, information that can be gathered, but could be used to then inform some of the more quantitative information that's being gathered. And then we've already discussed the ideas of timelines and locations and what is available. And I think while it's difficult to gather data and to analyze it and to make sure it's of quality, I think that it's important for the department to, again, go right back to where I started, identify what it needs to make what decisions, collect the information and analyze it, and then make those changes.
Thank you very much. Any follow-up, Emily Knockleby?
Yes, thank you. And I think as we progressed through COVID and we were raising mental health issues, which are clearly linked to addictions. You know, as my colleague mentioned, we heard a lot about the on-the-land funding, and it, like I said, it's very disappointing to see the lapse in that, because really it was being sort of touted as our savior, and you know, a lot of deflection to it as the response from the government, and then to see that they didn't even spend, you know, all the money is quite frustrating. I think around that, you know, here we are a year or so later finding that out, that didn't get spent. So I want to kind of come around like the transparency and sort of the public facing information around addictions, you know, and the reporting. I find it quite frustrating when I come to the department trying to get an idea of, you know, how many people have attended the emergency room with an attempted suicide or an overdose or you know, extreme intoxication, those types of things, and being really told that that data is not available. And, you know, maybe when they do the yearly wrap up of everything, we might get a report then, which is, you know, quite a bit past the date in which that data came from. So I guess my question is sort of what kind of public reporting structure and methodology does the GNWT need to be providing to residents? To me, like, I just can't understand that the software that runs the emergency room can't spit out this kind of data, because in my world, I've never worked with software that doesn't do some sort of analytics on the information that you're coming into, and I can't imagine healthcare software wouldn't be that way too. So what can the department be doing to get that out of their software, I guess, and then make that publicly available so we are more aware of the issues, because there's a lot of mystery and lack of information, lack of clarity around really what is our addictions issue, like how big is this problem? Because I can guarantee you, I know more people that are drinking, and they're not going to show up in what the GNWT is gathering at this moment. So I think we're heading down to a path where it's not just our marginalized groups that we've been talking about for 20 years, it's now becoming other people within our society. So I guess that's my question. Thank you.
Thank you, Emily and Alcovy. Ms. Schwartz?
Thank you, Mr. Chair. Thank you for the question. So I'll start, and then I'm sure that my colleagues will have some information to add, because we do talk in the report quite a bit about, you know, outcomes and measuring outcomes. And I think some of the observations that we had that are pertinent to your question is that, you know, a lot of the information was aggregated that was being collected or that was being used. So it's very difficult to analyze and expose trends when things are at an aggregate level. While for the facility-based treatment, the information was disaggregated and we were able to look at it, we found that the department wasn't routinely analyzing that information. And that's where we did our own analysis, and we found that, you know, some trends that the department would probably find useful in examining a little bit closer. So I do think that there's work to be done there. In terms of public reporting, I mean, I think the GNWT does already have some avenues that they use, such as their annual report. And so I think in terms of the actual vehicle for public reporting, it might be something that, you know, a committee like yours would want to reflect on to see what more information you would want in the public reporting that already exists, or if there is new tools that you wanted to use for public reporting. Thank you.
Thank you. Emily Cleveland, over to you.
Thank you very much, Mr. Chair. My first question is in regards to, I know that the Office of the Auditor General is really focusing on ensuring that reports are as concise as possible. And so I'm wondering if there are findings that did not make it into the audit report that the Office of the Auditor General wanted to be able to share with people of the Northwest Territories or with committee. Thank you.
Anyone? Ms. Thomas, go ahead.
I would say that our audit report contains all of the information that we felt was necessary to bring to the public and to the Legislative Assembly's perspective.
Emily Cleveland, over to you.
Thank you very much, Mr. Chair. Mr. Chair, my next question would be whether or not the Office of the Auditor General is satisfied with the response that they received from the Department of Health and Social Services, or if there are areas within the response that the Office of the Auditor General either would have preferred more focus and detail, or if there are areas that given the response from the government, the Office of the Auditor General would like to draw our attention to. Thank you.
Thank you. Ms. Thomas?
Start that, and I'll probably pass it over to my colleagues. I would say that the response that the action plan that we received is a good start. It really is up to the department to determine the steps that they need to take, and our role would be to determine whether or not follow-up work in the future was required. With respect to the timelines, for example, I think it's important to understand the breadth and depth of work that the department plans to carry out, and I think it's also important to understand each of the responses, each of the actions as a whole, in addition to simply looking at them individually. The timelines themselves, I think, once we understand the breadth and the depth, and then the scope and the resources that will be required, then it will be easier to understand if the timelines themselves make sense. But we do think that the responses themselves are heading in a good direction, and I'll ask my colleagues.
Emily Cleveland, over to you.
Thank you so much, Mr. Chair. On the same vein of transparency, I think one of the things that is so important in this topic, especially when we're talking about equitable access and whether or not people know about services that are provided, while this is a very difficult discussion, I think there is momentum that's created in this process of being able to have these conversations. Hopefully people are listening today and will get to hear us talk to the Department of Health and Social Services. But along that same line, to continue that momentum and continue that conversation, I think it's so important that the people of the Northwest Territories are included in the conversation of what changes are being made at the department, because maybe in that process they're finding out about a policy or a process that they didn't know before, or they're finding out about a program or a job opportunity. And so I'm wondering if the Office of the Auditor General can speak to recommendations for how committee is part of that process, whether that's additional public hearings, and when the Office of the Auditor General would recommend that committee have those types of public-facing meetings throughout this process with the department. Thank you.
Thank you. Ms. Thomas, go ahead.
Very much for that question. I think it's a really, really good one, and oftentimes I think that a hearing is held on a report and the department comes to the table, we come to the table, and often we move forward, the department moves forward, the committee moves forward, and it's not that it's forgotten, but another topic might come up, and as you said, the audits continue from our shop, and therefore the work sometimes has its moment, and then can sort of be put next door while something else gets addressed. So I think it's important for the committee to listen to the department, to hear what their plans are, what their actions are, and to determine when would be next to bring them back in. There is no set standard or idea. It could be very soon if you feel that you need more information quickly. It could be a longer amount of time if you feel that that what you hear is that they're heading down a path and you want to get an update or a progress report. I would say that it really is up to the committee to determine that, and we, in our role, what we will do as part of the team's strategic audit planning process, we will continue to do our own informal monitoring of their progress and determine whether or not at a later date we're going to carry out a follow-up audit to, at a point in time, determine whether or not our recommendations were implemented, and equally important, to determine whether the outcomes and the services that we identify as being not as far advanced as we'd like to see right now, if they've moved forward.
Yeah, thank you, and I think committee very much views its role as making sure we follow up on these audits, because there's often a remaining small percentage that never get implemented, and often the reasons as to why they are not being implemented are very revealing in themselves. So we have a sack of audits that we are slowly going through and drawing the departments back in before us to see what's outstanding. With that, I'll turn it over to Emily Simler.
Thank you, Mr. Chair. After the AOG has done their audit, on an audit like mental health and addictions, so you're going in to a territory that is one of the highest rated, with under both of those areas, And do you think there's an impact, and I guess this is because we don't have our own facility, our own treatment, our own, that way we can't follow through a whole process in our own territory, because I know every one of us around this room, everyone in the territory, when we all went around and like during our election campaign, the biggest thing that everybody heard was drugs and addiction and homelessness, and it's usually related to addictions and mental health. But the people in the territory are pleading for a territorial treatment facility, whether it's to help with mental health and addictions, like we're not talking about mental health with people with schizophrenia and things like that. I know they have addictions too because we have them all in our community. But a lot of our mental health are depression and related, and in our isolated communities, like I raised again, like in our community of Tuck, they're struggling right now, and our MLA is there, with his community, trying to deal with a lot of that. So do you think that when you did or have you done other territories or provinces under the same mental health and addictions, not having an addictions facility is impacting us, or we're worse off?
Thank you, Emily Semler. Ms. Schwartz, go ahead.
Mr. Chair, thank you for the question. So the GNWT is the first territory that our office has done an audit of addictions, in terms of your question of whether we've done that work elsewhere. And we don't audit the provinces, so we would be limited to the territories. In terms of the in-territory facility, we didn't make any recommendations of whether or not we thought that the territory should have its own facility or not. What we did observe in our work related to equitable access is that having some services only in some locations, whether that's in the territory or out, does cause barriers. So in the case of an out-of-territory facility, obviously people would have to leave the territory. There could be concerns about people feeling that treatment might not reflect their culture and that sort of thing. The department has stated that by entering into service agreements with multiple treatment centers outside the territory, that it can actually provide more options to its residents. So that might be something that you'll want to talk to them a little bit more about. But our audit didn't focus on determining whether or not the territory should have its own facility.
Thank you. Ms. Semler?
No, that was my last burning question.
Any other questions from committee? Hearing none, there any further questions or comments from the Office of the Auditor General?
Thank you, Mr. Chair. I'll simply say thank you very much for having us here today. It's always a pleasure to come and speak about our work, and we're always available to answer questions and to listen to your ideas. So thank you very much.
Thank you, and on behalf of committee, we thank you for all of your audit work, and we look forward to working with the other half of your office on public accounts pretty soon, and then we'll be back here for the next performance audit. But with that, the department is not scheduled to join us till 2:30, so I will take a break and we will resume at 2:30. I'll now call the meeting of the Standing Committee on Government Operations back to order. My name is Rylund Johnson. I'm the MLA for Yellowknife North and chair of this committee. After hearing from the Office of the Auditor General, we will now hear from the Department of Health and Social Services on their response. With that, I'll turn it over to you, Deputy Minister.
Thank you, Mr. Chair. I'd also like to thank the committee for providing us with this opportunity to come and present the Health and Social Services System Addiction Prevention Recovery Services Work Plan. I would like to begin by introducing the officials that I have from me, both from the department and from the 3 Health and Social Services Authority. I have Ms. Kim Riles, the CEO for the Northwest Territories Health and Social Services Authority. I have Ms. Erin Griffith, CEO for the Hay River Health and Social Services Authority. Coming online, we will have Sarah Nash, the Director of Health and Social Services with the TCSA. Also online, we have Ms. Penny Hill, who's the Executive Director for Clinical Integration with the NTHSSA. To my right, I have Ms. Sarah Charkowski, who is the ADM for Programs with the department. To my left, I have Ms. Kyla Kakwe-Scott, who's the ADM for Corporate Services and Cultural Safety with the department. I also have with me today Ms. Haley Mado-Young, who's the Director for Mental Wellness and Addiction Recovery with the department. I also have Ms. Kathy Spooner, the Director of Corporate Planning, Reporting, and Evaluation from the department. And also we have Ms. Jenna Scarf, who is the Director for Mental Health and Community Wellness with the NTHSSA. Mr. Chair, building a quality health and social services system is a process of continuous learning and improvement. Audits are one tool that play an important role in driving the improved performance and ensuring we are being compliant with policies, standards, and commitments. This audit conducted by the Office of the Auditor General of Canada is valued by the Health and Social Services system as a key component of our overall approach to quality assurance. The department and the 3 Health and Social Services Authority recognize the devastating impact that addictions have on the lives of individuals, families, and the communities across this territory, and we are committed to enacting change to better meet the needs of those that are impacted. The Auditor General's recommendations align with the territory's key priority areas for addictions prevention and recovery services. Many of the initiatives that the Health and Social Services system had already implemented or that were in development at the time of the audit align closely with the OAG's recommendations, and it is encouraging to know that we are on the right track in many of these key areas. However, despite the existing services and the work that is already underway, we are aware that we can do better and we can do more. There are ways that we can do better at delivering and monitoring our services to ensure the best supports and outcomes for the NWT residents. The audit recommendations have highlighted some of these areas for us. The department and the authorities have agreed with all 7 of the recommendations outlined in the OAG report and have created a joint work plan to address these recommendations. The scope of the audit and consequently the focus of the work plan is specific to addiction services. As a result, the work plan that will be presented today is not intended to address the full spectrum of mental wellness and addictions recovery supports for this territory. The activities that will be undertaken as part of the work plan reflect important changes to the addiction prevention and recovery service delivery continuum. Implementing these activities will complement existing mental health and addiction services and initiatives to help strengthen our system. This work plan includes, as a foundation, consultation and engagement with Indigenous governments, communities, and service users to ensure that our efforts are guided by the voices of those that we are serving. We take the recommendations of the OAG very seriously and are committed to making the necessary changes, improvements, and adjustments. We are aware that the health and wellness of residents is impacted by our success in these efforts. As this is a system response, and the work plan, for this work plan, and the ultimate accountability for the work plan lies with me in my role as Deputy Minister. With your permission, Chair and Committee, I will begin the presentation, but I will also, the presentation will be shared by my colleagues, both from the department and from the health authorities. Thank you.
Go ahead.
We'll stay on slide 1 for one moment. Once again, thank you for having us here today, and our main goal is to focus on 3 priority areas. We're going to review the Auditor General's 7 recommendations for the addictions prevention and recovery services for the NWT. We're going to highlight the existing initiatives that align with the Auditor General's recommendations, and we are also going to provide you with information on the work plan that the department and the authorities have developed together in response to the 7 recommendations. Slide 2. The OAG conducted the audit of addictions preventions and recovery services in the NWT for the time period, as you will have known from the report, from August the 1st, 2016 to July 31st, 2021. The objective of the audit was to determine whether the department and the authorities provided addiction prevention and recovery services to meet the needs of NWT residents. The audit involved examining and analyzing key documents from the department and the authorities, and the OAG also interviewed officials from the department, the authorities, our Indigenous governments, and organizations. Findings of the work led to the OAG to make a total of 7 recommendations, which are intended to assist the system, the health and social services system, to improve the delivery of addictions prevention and recovery services. The department and the authorities have developed this joint work plan to address the OAG's 7 recommendations. The next slide. As we discuss addictions prevention and recovery services in the NWT, it's important to note that many of the OAG's recommendations complement and validate the priorities of the department and the authorities. Many initiatives have already begun and were either being implemented at the time of the audit or were in the development. There are many examples of this alignment, and the purpose of this slide is to actually provide a sense of some of the key areas where the OAG findings let us know that we are on the right track with the work that we are doing. Some of the examples, and as I said in my opening comments, please note that we know that we have a lot of improvement that we need to do, even though a lot of this work is in alignment with the work that we're already doing. So some of the examples of the work that we had currently already in place at the time of the audit. For example, we have established in the Department of Health and Social Services a cultural safety and anti-racism unit. And this includes the creation of key positions. One of those is the Director of Community, Culture and Innovation. We have a Manager of Cultural Safety and Anti-Racism. There is a Senior Advisor for Indigenous Knowledge and Wellness, and a Senior Indigenous Research and Evaluation Specialist. Another example is that we have mandatory training for all health and social services staff, such as the GNWT Indigenous Cultural Awareness and Sensitivity Training, which is also known as Living Well Together. And you folks know that that is 8 modules that occur online. And I would just point out that our staff also were instrumental in helping develop that training, that mandatory training. Within the department and for the health authorities, we have a cultural safety and anti-racism training that is 2 days of in-person training, and that, again, is mandatory for our staff. We have established an Indigenous advisory body to provide guidance and advice on how to incorporate Indigenous tradition, culture, and healing practices within the health and social services system. We've implemented Stepped Care 2.0, which is an approach for our community counseling program. It uses recovery-oriented approach to provide same-day access to flexible mental wellness and addictions recovery services. Since implementing this model, the community counseling program has eliminated the need for official wait lists and for folks who are receiving community counseling. Step Care 2.0 has paved the way to enhanced integration for services across the system, as well as the introduction of e-mental health options. We've established as you know, child and youth care counselors across all regions, and this has improved access for mental health services for children, youth, and their families in the Northwest Territories. We have established community-based program options which enable communities to take the lead in delivering wellness programs and enhancing cultural safe options available at the community level. Examples of these are achieved through our Addictions Recovery and Aftercare Fund, the Peer Support Fund, Community Suicide Prevention Fund, and the On the Land Fund. In addition, there are several other initiatives currently in development that also align with the responses to the OAG findings. The Department and the NTHSSA are collaborating on the development of Indigenous patient advocate positions and also an Office of Indigenous Client Experience. The department is actively working to establish an approach to incorporating equity frameworks and tools for the health and social services system to use in policy and program development. And we are taking steps to establish key addictions recovery and aftercare supports, including managed alcohol, medical detox, and traditional sober housing options for people returning from addictions treatment. In addition to the items that I have mentioned, the OAG findings and recommendations will also inform the development and the final release of our territorial alcohol strategy, which will be coming later this calendar year. We're going to move to slide 4, and I'm going to hand it over to Sarah Turakowski to take that.
Go ahead.
Thank you, Joanne. Thank you, Mr. Chair. So as Joanne has mentioned, while the knowledge that in many areas we're on the right track is extremely validating, we also know that there remain areas for improvement and those where we can do a better job of supporting residents impacted by addictions. The Auditor General's recommendations have highlighted these areas that are in need of change, growth, and improvement. The Addictions Prevention and Recovery Services Work Plan 22 to 24 highlights new actions that the Department and the authorities are proposing to take in direct response to the Auditor General's findings and recommendations. However, it's important to keep in mind that this is not a standalone document. As has just been discussed, there are services in place and work underway that will complement the proposed activities outlined in the work plan. With the implementation of the work plan, it's anticipated that improvements in the following areas will be realized. Increased understanding of residents' self-determined mental wellness and addictions recovery needs to inform our program planning and priority setting. Enhanced partnerships with Indigenous governments and communities to ensure a continuum of services that better meets the addictions needs of residents. Improved access to culturally safe addictions prevention and recovery services. Increased consistency and coordination of addiction services and aftercare. And an enhanced ability to track community-identified and service user-identified outcomes. In the coming slides, we will speak to each of the 7 recommendations, as well as the activities that the Health and Social Services System will be undertaking to address them. As we move through the description of the planned activities, it's important to keep in mind that although lead organizations have been assigned to each activity, the work that will take place will be collaborative and will include involvement from the department and all 3 health and social services authorities, as well as our Indigenous and community partners. Next slide, please. So the audit found that despite having made commitments to equitable access for health and social services, we've not determined what equitable access to addiction services look like, and we have not identified the actions required to achieve equitable access. Accessibility is of critical importance when it comes to the ability of programs and services to meet the needs of residents impacted by addictions. That's understood. Services cannot be effective if they are not accessible to the people who need them. The Auditor General's recommendation in this area is that the Health and Social Services System needs to determine how to provide equitable access to addiction services in the Northwest Territories, including a focus on identifying where and how services should be made available to reduce barriers to access. This needs to be done in light of the Territory's operating environment and related challenges. In response to this recommendation, and by March 2023, the Department of Health and Social Services will be engaging with Indigenous governments and communities to inform a definition of equitable access as it relates to addiction services. So key components of this work will include utilizing the aforementioned health equity assessment tool that's currently in development to guide the adoption of a definition of equitable access to addiction services that is based on engagement with Indigenous governments and communities. Indigenous community leadership via the Community Wellness Plan renewal process, Indigenous governments via the Indigenous Advisory Body, NWT communities via the NWT Association of Communities Annual General Meeting, and individuals with lived and living expertise via the Mental Wellness and Addictions Recovery Advisory Group. We will also be developing a comprehensive map of addiction services, both existing and requested, to inform long-term planning and priority setting in accordance with the established definition of equitable access and ongoing engagement with community partners. In 2023-24, the Northwest Territories Health and Social Services Authority will use the findings of the department's engagement activities to develop an approach for the delivery methods and locations of key addiction services, aiming to reduce barriers where possible and within existing system capabilities and capacities. So that work will include establishing a territorial addictions working group with key stakeholders and developing a work plan to identify and address barriers to health equity for addiction services. While it's understood that improved access should happen as quickly as possible, it's important that we take the time to work with communities and Indigenous partners to understand what equitable access means to them, their preferences when it comes to access, as well as the larger picture of how community-based programs and services are part of the overall continuum of services and therefore part of the solution when it comes to access. We do not want to establish approaches based on our understanding and services alone. We need to take the time to hear from communities and from the people who use our services to understand what access means to them and how we can work together to make improvements. And in the meantime, we're continuing to take steps to enhance services at the community level through the administration of community-based funding opportunities and to improve our communications when it comes to ensuring that residents understand what services are available and how to access those services. We do know from our recently administered Addictions Recovery Experiences Survey that oftentimes people are not aware of what's already available in their community, nor how to access it. So we recognize that that's a barrier. Next slide, please. So recommendation number 2, the audit found that we did not do enough to assess the needs of diverse subpopulations, such as LGBTQ+ immigrant and refugee communities and other non-Indigenous racialized groups. There's been a lot of done work to try to understand the needs of residents when it comes to addiction services. So examples of this include forums, surveys, consultations, engagements, etc. However, none of this has been done in a way that specifically targets diverse subpopulations. This is a missed opportunity that may be impacting on the quality and accessibility of our services. These communities are at increased risk of experiencing barriers to access, and so it's important to take the time to understand their unique experiences and needs. The Auditor General's recommendation in response to this finding is that we need to identify the addictions prevention and recovery needs of those diverse subpopulations. The Health and Social Services System agrees with the importance of identifying these needs to reduce barriers and improve access and has committed to developing an approach to the collection of service user experience and satisfaction data that includes additional demographic categories to capture the needs and experiences of diverse subpopulations. So by the end of 2022-23, the department will create a system approach to the categorization of demographic information. This work will include researching best practices for categorizing demographic information and then developing an approach for categorizing that information once it's collected. And then in 2023-24, the department will combine the existing Community Counseling Program Service User Satisfaction Questionnaire and the Addictions Recovery Experiences Survey that was recently completed into one single questionnaire that will include those newly identified and adopted demographic categories. So the survey will target not only current and former service users, but also the larger public in the hopes of capturing the perspective of individuals who have not been able to, or maybe who have not wanted to access our services and supports. It will help us understand better the reasons for those access choices and barriers. And then the department will administer that survey using a mixed methodology of online and paper-based collection. The results of the survey will enable us to analyze the results in a manner that can pull out responses from diverse subpopulations and use that information to make shifts in our approaches to programs as required. We're going to move to the next slide, please, and I'm going to pass it over to Jenna to continue on.
Go ahead.
We do not provide the aftercare supports resident needed to support their recovery goals. This was evidenced in a lack of formal aftercare plans on files despite this expectation appearing in system standards, a lack of active outreach following treatment, as well as a lack of services to connect people to. Having a documented aftercare plan on file assists service users and counselors to prepare strategies and services before a person returns home. Doing this work ahead of time ensures that the person returns to their home and community knowing what supports they have and immediately being able to access them, as opposed to needing to sort this out on their own during what is already a stressful time. Documented plans can also assist with continuity of care when there's turnover in counseling staff. The Auditor General's third recommendation is to develop a standard approach to aftercare planning that includes ensuring service users who attend facility-based addictions treatment have an aftercare plan before they leave for treatment, and that it is reviewed with the service user during the recovery process as their understanding of aftercare services may have increased, and facilitating access to aftercare services when service users return to the Northwest Territories. The Health and Social Services System agrees with these findings and the recommendation. The development of a comprehensive aftercare plan is a key piece of work that those supporting residents to access treatment should be doing. The development of an aftercare plan helps individuals to identify the services that they feel will help them maintain the successes they have achieved in treatment. Having a plan in place before returning from treatment enables the person to focus on their recovery and not on trying to navigate the system. We agree that this is an area where we have not been doing enough. The implementation of the Step Care 2.0 approach in the community counseling program sets the stage for a more holistic and person-centered approach to aftercare planning. The Step Care 2.0 model is focused heavily on providing options for residents to choose from, including those that exist outside the health and social services system, like community-based and traditional cultural services. Through Stepped Care, counselors are being supported to practice in ways that focus on care planning, including aftercare planning on both formal and informal supports based on what the person thinks will be most helpful for them. To complement the stepped care approach and to improve supports specific to aftercare, the Northwest Territories Health and Social Services Authority will complete a review of best practice and national standards in addictions recovery and aftercare, and implement a consistent approach to aftercare planning and documentation that ensures alignment with person-centered practice and cultural safety, and that includes requirements for planning to take place prior to treatment. The plan is reviewed with the service user during the recovery process, and for active outreach and offering of supports post-treatment, and implement standard operating procedures and tools to support providers in the implementation of the aftercare planning approach. This work will take place by the end of this fiscal year and will include the development of tools and processes that will ensure a documented aftercare plan is clearly identified on the service user's file prior to leaving for treatment. While this work plan does reference the development of a standardized approach to aftercare planning, it is not simply about the development of a plan on paper. It is about ensuring regular updates during treatment, proactive connection upon completion of treatment, and active outreach to ensure that residents accessing addictions treatment are connected to resources and set up for success upon returning to the NWT. By the end of 2023-2024, the Northwest Territories Health and Social Services Authority will implement a system education and training plan that targets primary care practitioners, non-government organizations, and other care providers who make referrals to addictions treatment. Next slide. The audit found that there are gaps in the coordination of addiction services, including gaps in the process to connect residents to services delivered by organizations outside the health and social services system. An example of this is lack of an established process in any of the 3 health and social services authorities to help community counselors understand how to connect service users to services offered by Indigenous organizations. Coordination between and amongst the various addiction services is a key component of ensuring accessibility and reducing barriers. The more coordinated the service system is, the easier it will be for people in need of support to navigate the system and find the services they need. The Auditor General's 4th recommendation is to improve coordination of services across the territory by creating a formalized referral process to help connect service users to the required services and evaluating the key positions that can facilitate referrals across services and where these positions should be located. While many addictions recovery services available to residents of the Northwest Territories are accessible through self-referral, it is recognized that residents and providers are not always aware that the services exist or how to access them. The work that has been previously mentioned around a move to a Step Care 2.0 approach is aligned with this recommendation as well. In line with the focus on options, the Step Care 2.0 approach includes the development of tools that support providers to be familiar with the various programs and services that exist in their communities and regions, both formal government-based services and also community-based and informal services. In addition to the work underway as part of the Step Care 2.0, by the end of March 2023, the Northwest Territories Health and Social Services Authority will address this recommendation by creating a consistent process for both providers and self-referrals that includes key referral points and pathways to accessing addiction services. Key components of this work will include providing a consistent approach for transitioning service users to and from out-of-territory treatment facilities to community-based care providers. This will involve identifying and communicating key positions and key stakeholders responsible for providing addictions and recovery services, including both government and non-government, developing and implementing standard operating procedures to standardize the approach for providers referring to addiction services. In 2023-2024, the Northwest Territories Health and Social Services Authority will implement onboarding processes and competency-based orientation plans for all practitioners that outline the pathways for accessing addictions and recovery services and implement system-wide communication outlining the process to self-refer to addiction services for both providers and service users. And next slide. Over to Sarah.
Recommendation 5. So the audit found that not enough action was taken to remove barriers to cultural safety, that traditional Indigenous systems of experience were not recognized in hiring practices, and that we have not reviewed our policies to ensure that they support a culturally safe system. Culturally safe addiction services are essential to ensuring the best outcomes for Indigenous residents. However, the health and social services system has not done enough to incorporate Indigenous knowledge into addiction services, nor have we done enough to recognize Indigenous qualifications and expertise in our hiring practices. This creates barriers to employment for Indigenous people who could be providing culturally safe addictions care. The Auditor General's 5th recommendation was to improve the cultural safety of addiction services, and that this should include reviewing policies to identify any barriers to delivering culturally safe addiction services and working to remove those barriers, and developing and implementing a strategy to adapt the current hiring approach to formally recognize Indigenous qualifications. So this was a recommendation that was difficult to hear. Over the past several years, the Department of Health and Social Services has been taking significant steps to improve the cultural safety of our services. Extensive work has been done to educate system staff about cultural safety and anti-racism, and to ensure that the voices of communities and Indigenous people are built into the governance of our entire system. This is work that we're committed to because we know that this is what needs to happen in order to reduce the disparities we see in health outcomes between Indigenous and non-Indigenous residents. But we also know that it's our duty, as we work towards reconciliation, to look at ourselves and our systems and work to make them better and safer for Indigenous people. Because of all the effort that has been put into working towards cultural safety, it's hard to hear that we haven't done enough, but it's also fair. Moving the needle on attitudes and beliefs, systemic racism, and colonial practices takes time. These are not accomplishments that can be made overnight. And while significant progress has been made, we still do need to do more, and we need to focus on improvements to the cultural safety of addiction services specifically. So by the end of 2023-24, the Department of Health and Social Services will conduct a review of standards and policies associated with key addiction services, so including the Community Counseling Program and the Facility-Based Addictions Treatment Program, to identify barriers to cultural safety and to inform efforts to remove or reduce those barriers. This will be done in partnership with interested members of the Indigenous Advisory Body. The results will be shared with the Health and Social Services authorities to inform complementary changes to operational policies and procedures. In addition to this, the 3 Health and Social Services authorities will review and adjust job descriptions, core competencies, and screening and interview processes for key addiction services positions to ensure the inclusion of Indigenous qualifications. So in that work, the NTHSA will engage in discussions with community leadership and Indigenous organizations on how to appropriately incorporate Indigenous qualifications into job descriptions, ensure that job descriptions, core competencies, screening and interview processes reflect and incorporate Indigenous knowledge and qualifications, and improve orientation processes and identify mandatory training requirements of positions that are delivering addiction services. And while this work will begin this year, it's anticipated that it will take into the next fiscal year to fully achieve and implement. Next slide, please. This is recommendation 6. The audit found that we did not collect or analyze data to expose trends about outcomes for residents, including those from diverse subpopulations. So while data is collected, it is not necessarily collected or analyzed on a disaggregated basis, meaning that we're missing the opportunity to identify trends for specific subpopulations. This impacts on the ability to adjust services as required to best meet the needs of those residents. There is a need to establish an approach to disaggregated data collection and the routine analysis of that data.
The Auditor General's sixth recommendation is to determine the disaggregated data required to understand whether addiction services are working, including for diverse subpopulations, identify trends or anomalies, and use the information to adjust services as needed. So by the end of 2023, the department will complete an examination of the ability to disaggregate program data based on our current data collection approaches and the appropriateness of collecting data on additional demographic groups, including LGBTQ+ community, refugees, and non-Indigenous racialized groups. This work will include conducting a review of best practices on the collection of demographic data, compiling an inventory of existing demographic data collection across key addiction programs and services, completing a feasibility assessment around collecting additional demographic categories, including for those diverse subpopulations that were mentioned. So following this, and by the end of March 2024, the department will implement an approach to demographic data collection and the analysis of monitoring data that includes administrative data and self-reported experiences. The results of the analytic approach will then be used to inform adjustments to services as required. Next slide, please. So recommendation 7. So the audit found that we did not establish outcome indicators for most addiction services. When there is a lack of performance measurement, it's difficult to know whether results are being achieved and whether the services are helping people or not. Measuring performance also helps to ensure that funds are being used in the most effective way. The Auditor General's 7th and final recommendation is to establish short, medium, and long-term outcomes for addiction services, establish indicators to measure those outcomes, use those indicators to monitor results related to addiction services, and adjust our services as necessary based on those results. The Department of Health and Social Services will develop logic models and monitoring frameworks for the community counseling program and other key addiction services, including health and social services funded, community designed, and delivered services. This work will identify short, medium, and long-term outcomes, as well as key indicators, and will embed applicable community-determined outcomes into the overall monitoring approach. The following activities will be completed by the end of March 2023. Engagement to determine community definitions and understandings of outcomes for addiction services. Establishment of an overarching logic model and monitoring approach for all core mental wellness and addictions recovery programs that includes short, medium, and long-term outcomes, including those community-defined outcomes and indicators. Beginning in 2023-24, the department will implement the monitoring framework and then use the results to inform shifts in service delivery as necessary and feasible. Next slide, please. So that concludes the overview of the approach that the department and the 3 health and social services authorities have developed to address the Auditor General's 7 recommendations. This work plan represents the commitments and key activities which we believe will help to drive change and improve the responsiveness of the addictions prevention and recovery system. We understand the importance of our success on the lives of families and communities impacted by addictions, and we're committed to the implementation of this work plan. As we make progress on this work, the department will be pleased to communicate progress on a schedule that meets the needs of committee. I thank you for this opportunity to convey our approach to the continued improvement of addiction services in the NWT, and we value your insights and are open to your feedback and questions. Thank you.
Thank you very much. With that, I will now open up the floor to questions from committee, beginning with MLA Semler. Oh, actually, before I do that, would we be able to get a copy of your speaking notes? We heard quite a few new details today that were not contained in the work plan. Thank you for that commitment, Deputy Minister. MLA Semler.
Thank you, Mr. Chair. I have lots of questions, so you put me back on the list, I'm sure. So one of the, going through the different recommendations that, and with the presentation with the new information, one of the questions that popped into my head right away is, you know, like, we have this aftercare plan that we're developing, and we've heard this over and over again in our communities that we can send people out to outside treatment, and then depending on which door they entered to go out, not necessarily is there anybody waiting for them when they come back. And whether or not we have community counselors that are their caseworker that sent them out, or the Indigenous governments with the federal program counseling that they offer, sometimes they come back and there's nothing, we know that there's nothing. But this is not just, like when I look at your portfolio, like with the health minister's portfolio and the Department of Health, You're not in charge of housing. So a big component of a lot of the people that are going out to treatment and that are struggling with addictions, that continue with addictions, are housing. So what is the department doing? Like, I mean, this is not part of the AOG, but it is part of the aftercare plan. So what discussions are the Department of Health and Housing having on housing some of our residents that are coming back from treatment? Because if they come back homeless, then it's more likely that they're going to end up back into that cycle. So, thank you, Mr. Chair.
Thank you, Emily Semler. I know we have representatives from both the authorities and the department here, but what I propose is I'll refer all questions to you, Mr. Gatto, and you can redirect as needed. Over to you.
I'll start, and then I'll ask my colleagues to jump in as they feel appropriate. Thank you for the question, and you're absolutely right. There are the issue around aftercare is complex, and I think you've identified one of the key issues around housing, and we cannot help our clients be successful in their aftercare and their journey to sobriety or whatever issues they're trying to resolve. And so we do have, you may remember in some of our other conversations, whether it has been in session or business planning, we do have a partnership with our colleagues in housing, as an example, around transitional housing, a model whereby this past year we did a call out to our Indigenous governments and our partners around submitting ideas. We funded them for ideas around what are some models that you would look at that they would like to explore around transitional housing, and particularly we are targeting that initiative to be in support of aftercare. And so where we're at right now is we have 4 proposals that we're working, and all of them are different, and we are working with those partners to map out what that would look like for their communities and for their regions. And I won't be naive, we do not have funding for the actual, if you look at, say, required an infrastructure, a building or a renovation of a building. But the key piece to that is to at least hear from community and from our Indigenous partners around what they have in mind, how we can partner with them. We definitely need the support of housing. And this is an initiative that we have co-led with them, with housing and us. And so, yeah, I would just echo that you are spot on, that housing is a key part of this, and we are working with our housing colleagues to try to determine how best we can collectively help address that issue. I am going to look to Sarah or Jenna to see if there's anything you wish to add.
Thank you, Ms. Chirikowski.
Mr. Chair. I think that's a great answer, Joanne, and that is a really good example of the partnership with Housing NWT. Recognizing, of course, that you're correct in stating that homelessness is definitely an impediment to addictions recovery. The only thing that I would add to it, and Jenna, I would certainly invite you to add any detail or context to this, is just that it would also be part of the work of an aftercare plan, right? That if somebody is homeless or has insecure housing, and that is impacting on their recovery plan, it would be part of the work that a counselor would do with somebody. There wouldn't be an intention to take a person who is experiencing homelessness, send them to treatment, and plan to bring them back to return to homelessness. There would be that work that would be done ideally prior to the person leaving, to, what do we need to do? Do we need to fill out an application? Do you need to get on the wait list? Are there arrears you need to clean up? Like, that would be some of the work that would be done as part of the process before they go, and so that time can kind of, rather in treatment, some of those wait lists and things like that, or just, that we're being proactive in setting that up so that when they come back, there's a plan in place. They're not hitting the ground with nowhere to live. So if it's okay with Mr. Chair, I would invite Jenna to add to that from an operational perspective if I've missed anything.
Yeah, on this question, so if I'm homeless and I'm living in Wati and I go out for treatment, where am I going home to if I'm homeless? That, like today. So I know that this is something that with housing and transitional housing, but today if we have caseworkers, where are we telling them to go live? Like, oh, we'll send you out for treatment, when you come back, you're still homeless. And we know that the housing wait list in pretty much every single one of our communities is not even moving. So if if I want to answer my resident or my constituent, where am I going to go when I come home? I don't know. Like, can you answer that as a caseworker? Thank you.
Thank you. Deputy Minister?
Thank you for the question. I can't answer the question as far as what is available for them for housing because that's not the department that we work in, but that's not a good enough answer. Well, if I bring it back to the audit, you would have heard from the OAG in their answer to you that what was audited was how folks come into our system and leave our system and vice versa and go to treatment and then come back. So a piece of that aftercare is, as Ms. Cherkowski has noted, is around ensuring that we have a documented approach to that aftercare. And we have a consistent approach to that. And you would have heard in the work plan that although the audit only looked at the GNWT Health and Social Services processes, there is plans to work with our partners and to be able to find out what are those needs of those residents. So whether it is through an NGO that they are being referred to for treatment or another entity. But ultimately, it's about working with that client, helping to understand what is success for them, and helping put them in touch both individually with the resources to help them, so make sure that they have access to the resources that they require. But it also means that we, on behalf of our residents, know that we need to continue to work with housing, and we need to continue to work on the issue around homelessness. And a whole nother conversation is around the work around ISD, and the priority around ISD to be looking at the population around homelessness. And so there is another whole piece of work around that area that is underway, and it's not necessarily, it aligns with the work in relation to this audit, but you've identified a complex issue, and that is bigger than health and social services, but at a minimum, working with that client, ensure there's a plan in place, ensure there's touch points when they come back to community. And if it's not coming back to their home community, where do they want to come back to? And how do we work with them, and how do we engage our partners with them to get the resources that they need? And I am going to look to my colleagues to see if they have anything else they wish to add.
Seeing none, thank you for that. Next, I'll go to Emily Cleveland.
Thank you very much, Mr. Chair. I'm very thankful that the department is in front of us and has given us this time in order to be able to have this conversation. One of the things that was said today by the Office of the Auditor General that is where I want to start today. And it was just a side comment, but it was a comment made in relation to the work that they've done with the department. And it was everyone in the territory has access to free same-day services. Ironically, this morning I sat and talked with a constituent about trying to access counseling for their child who's in crisis mode. And they are unable to access private counseling services in town. Many of the private counseling services in town, which is a paid-for service, won't even take people and put them on a wait list right now because they're so full. Accessing same-day services, people don't want to leave voicemails because they question the security of the privacy in that. And on multiple phone calls to the phone number, they don't get an answer to the phone line. Beyond that, you have the CYCCs. There's two sides to that. The first side is that kids feel that their privacy is in jeopardy sometimes or aren't comfortable with that option. And the other one that we hear quite often from MLAs in this room, including Yellowknife MLAs, is there's not enough to go around. And so my concern there, and I mean I have other pieces with that I'd like to discuss today, but my concern there is that I fear that the gap that exists is far greater than what we perceive it to be. Because when we sit in this room and we have conversations, even in social development, with the department, and we talk about what is happening and what work is being done, we hear really good things that are happening at the department level. But when we turn around and we talk to our constituents who are in crisis mode or who are in need, we hear a much different story. And so my concern is that there is a gap there, but I think it's greater than where we're starting today. And so I'm wondering how the Department of Health and Social Services is undertaking the gap analysis and how they have found working through this process so far. Thank you.
Thank you, Emily Cleveland. Deputy Minister?
Thank you. I want to make sure I understand the question, Emily Cleveland. So are you asking around the gap analysis specific to mental health services? I want to make sure that I understand what the question is, so that I don't go down a road you don't want me to go down.
Thank you, Emily Cleveland.
Thank you very much, Mr. Chair. I feel like mental health services and addiction services also often come hand in hand. This OAG report is in relation to addiction services, but often the avenue of getting to addiction services is through mental health services. So I wouldn't turn away either of those rabbit holes. Thank you.
Deputy Minister?
You're right that they are very intimately related to one another, and we have them in our same divisions often. So I wouldn't debate that we have gaps in our services, and it's not just in mental health, it's in other services as well, primary care, acute care, and we can go on. What I can say is that, as I mentioned in my opening comments, that we have eliminated our wait times, and some of that has been the lessons that we've learned through COVID. It's the ability to be able to provide a variety of services to clients. So when I think about stepped care, and I think about the way in which we are trying to provide services to clients in a variety of ways, it's really being able to, if that client, for example, that you gave as an example, they cannot get their child into a face-to-face appointment, then what are some other options that we can offer them? And I know the access is the piece that I believe that you're speaking to. You can't get through the phone line and you can't get into the door. And so it's really about making sure that how do we ensure our clients know what services are available to them and beyond the face-to-face. And so for many clients, that's what's ideal to them. But when face-to-face is not the option that's available at that moment in time, it's the first piece of this scenario is ensuring that everybody knows what the variety of services that are available. Do we have enough services for everybody in our system at any given time? That can be, it depends on what the service choice that they're wishing to have. And so we do have gaps. You know that we have vacancies. We have mechanisms whereby we are trying to determine other ways to provide services to our clients. And I think that ultimately at the end of the day is ensuring that folks do know what is available to them, regardless of where they live. Because for some communities, the face-to-face is not an option every single day. And so ensuring that they know what our e-mental health services are, what our helpline services are, and of course in acute situations, what's available to them. I am going to pause there for one moment though, and I'm going to look to my colleagues to see if they have anything they wish to add.
Go ahead, Ms. Scarr.
I would say that our teams over the past couple of years have really tried to open up services to the best of their abilities. So I would strongly encourage, if you are hearing that somebody can't get through, to please leave that voicemail or please leave the message, because we've done a lot of targeted support to our staff to open up same-day services, especially in Yellowknife region. That was actually the region that had the largest wait list that we had to work through, but they have gone from like very large wait list to no wait list. So I would encourage them to leave that message. They really try to return all the phone calls that they get in that office. So.
Thank you. Any follow-up, Emily Cleveland?
Yes, please. Thank you very much, Mr. Chair. My next question is in regards to the mapping that is being done on the addiction services, so both existing and requested, and I'm wondering, will the mapping include any kind of public-facing outputs? Thank you.
Thank you. Ms. Chicago?
Thank you. I'm going to ask my colleague, Ms. Capui-Scott, to answer that question.
Capui Scott?
Thank you, Mr. Chair. So this is a new commitment building off of something that we tested in doing some of the work around early childhood development, which is another area where it's very complex. There are things that the GNWT is providing. There are things that Indigenous governments are delivering. There are things that community service providers are involved in. And so having a sense of the early childhood sector is hard to know what that picture looks like, and it's so different from community to community and region to region.
And we were able to do that and put some visuals behind it in order to inform the internal work that we're doing in the system. So it's something that we thought might be useful here, particularly as there are new funding streams. In some cases, we know that community partners are delivering programs where it might not even be clear cut because some GNWT funding is going towards it. Maybe there's some federal funding. There's just a varying picture, and it can vary even year to year. So we're looking to work with someone to support that visual mapping, and yes, would hope to have that available as a public-facing thing because it's helpful for residents to be able to see what that picture looks like. For sure in their own community, recognizing that those things can always change, but also to have a sense of what's available in other communities. And so that's a piece too that we're looking at in alignment with the community wellness planning renewal process, so that we're not going out multiple times to talk to the same groups of people about slightly different but really super connected things, and to be able to instead have that be part of an ongoing conversation rather than sort of one-off once a year check-ins.
Thank you. Any follow-up, Emily Cleveland?
Thank you so much, Mr. Chair. Mr. Chair, given that we know that there's inequitable access to programs and services, and that there is a huge gap as well as far as what demographics are being are able to access services or are target groups, I guess, for services, how is Health and Social Services planning to ensure that all residents of the Northwest Territories have equitable access even to participate in this work? Thank you.
Thank you. Deputy Minister?
Thank you. That is the work to be done. Ultimately, at the end of the day, it's an area where in the audit, while this is specific to, again, addictions, there are areas, pieces of these recommendations actually pertain to other areas in our system. So one, we need to be able to, part of this answer is actually we need to work with our communities, we need to work with our Indigenous governments to actually talk to them about what they determine to be equitable access as well. And so some of that is not about us defining what that means. It's really about working with our partners to make sure that we are meeting the needs of the residents as best we can. And so we don't want to be in a scenario where we are doing on to. We want to be able to work with. And so part of this this piece of work is highly reliant on us working with our communities and working with our service users, so the surveys that we've talked about, but ultimately at the end of the day, it's working with communities and our Indigenous governments to hear from them what they would determine to be considered equitable access to services. And I'm going to pause for a moment to see if anybody has anything they wish to add.
Scott?
I just wasn't sure from the question if that was partly about how we get equitable input into the mapping. And so if that is the case, the approach we took the last time was really just a snowballing. So we start with who we think we need to talk to. And every time we talk to people, we hear a little bit more that tells us who else we need to talk to so that there's opportunities to validate and make sure we have a complete picture. Recognizing at a community level, resources can vary wildly, right? It might be Auntie so-and-so who people know that they can go to, and there's an opportunity to recognize that too. So we're not starting off with this is what the picture is going to look like at the end and we're plunking information into it. It really will take shape as we go out and do the work and talk to people.
Thank you. I did have a question I wanted to ask. I'm curious to hear whether the department, the limitations they see in being able to kind of produce these outcomes and data. And I know the client survey is a good first step, and I'm well aware that, you know, people's recovery all look different and you want to let them kind of set their goals. But to me, to put it bluntly, what we want to see is if people who go to treatment stay sober, and we want to be able to do a cost analysis, which centers are working better, and, you know, whether that money is better spent perhaps on a different program or on housing, for example. And I think the current survey has its limitations. A, you need people to respond to it, and B, it only really works for people who are still in the system. So if someone has stopped going to counseling or stopped following their aftercare plan, either because they have, you know, become homeless and not sober again, or maybe they have got sober and they just stopped talking to anyone in the department, you know, we can't get that information. And I also question the limitations of, you know, 1 year, 2 year, 3 years out, being able to even phone someone and say, hey, just, you know, it's GNWT, you're checking up, are you still sober? I don't know if you can really even do that. So I would welcome any input on where the department sees its limits in being able to obtain all of that outcome-based data. Over to you, Deputy Minister.
Thank you. And yes, there are obvious limitations for sure. I think one of the things that when Sarah was speaking and doing her presentation, she talked about combining our surveys as an example and in broadening that information beyond not just the users. We know that there are folks who would be who don't go for treatment, who don't go that formal route, as an example, that we need to hear from. And so there are limitations in the way in which we collect the data. The one thing I do want to mention, and this is where we know we need to do better. That's the end story for this. But often the people who create the survey, who issue the survey and hear from the clients, we're a small jurisdiction. They can be the same person. And so sometimes when you look at the audit findings and you talk about, and this was many of the things we grapple with is, you know, you look at the audit and it says we do not provide aftercare because it's not documented. We provide aftercare, we know what the plan is, but it's not often documented because that's the relationship that folks have with clients. It's being more formalized in that process. So there are limitations in the way that we collect data. There are limitations in the way that we analyze our data, and we need to provide more outcome measures at the end of the day. And so that's the benefit of having had this audit, so that we in fact know that we need to do better. And we need to formalize much of this work that we're doing. We need to document better. We need to ensure that our staff know what the policies are. If we don't have a policy, we need to create that policy. So there are definitely some limitations across the system, but we know many of them through the audit, and we are prepared to make those changes. And so some of these can be, and we talked about short, medium, and long-term changes that need to occur. So I'm going to pause there for a moment just to see if anybody else wishes to add anything.
Go ahead, Ms. Chairakowski.
Mr. Chair. The only thing I would add to that response is that, you know, and I think it's been mentioned at some other point today already that, you know, addictions really is an individualized approach, right? And there are multiple paths to addictions recovery, you know, not just between people, but even in the life of one person, right? What they maybe tried, you know, 5 years ago and worked for them, you know, maybe due to life circumstances, it doesn't anymore. And so, you know, I think doing the survey is important as much as it's maybe not perfect. I do think it's important. It is something that we do target not only just to people that are using our services, but also to past users or people who have not used our services, as well as to family members and friends of people who, you know, maybe are struggling with addictions because they see things and they have important perspectives to offer as well. So I just wanted to mention that I do think it's an important exercise, and we did get a very high uptake, and there was a lot of positive feedback, but there was also a lot of feedback that really showed where we're not doing a good enough job or where we need to do better. The only other thing I would mention is that as part of the shift to the stepped care approach in the community counseling program, one of the things that we want to do a better job at is monitoring the progress and how well that relationship is meeting the needs of the person. So it's not a system level outcome monitoring. It definitely is a one-to-one relationship monitoring where every time somebody would come in for an appointment, they would be able to sort of fill out like 5 quick questions about, you know, how well is this meeting your needs? Are you seeing improvement in your life? And if those things are not sort of trending upward, then it's a good indicator to the counselor that, okay, like we need to shift or we need to try something different. So that is something that we're going to try to do. It's just in the community counseling program, but I think it's an important start. So I just wanted to mention that. Thank you.
Thank you. Emily Simler, over to you.
Thank you, Mr. Chair. I'm not sure which question I want to ask first. Okay, so there are the gaps in coordination of service, but also in the data collection. My question is going to fall within there, and it kind of goes to even what's just been released, like the statistics on the suicide. And I'm looking at these age groups, and 20 to 29 males are higher risk that on the stats that have shown. If you listen to the MMIWG report too, you know, when I went through that journey, it was so many women and mothers said we're failing our men. These statistics are proving that we're still failing our men in small communities, Indigenous men. And like you look at the High stats from 2018, and it says that the 10 to 24 are highest in Canada for substance abuse hospitalizations. So again, these are our youth, and then when you look into it, it's more they're dealing with their mental health in our communities. Communities are, suffering, and then when we look at programs and services like we have, I was mentioning this earlier, is we have the youth counselors in the school now, and we have the community counselors, but I was 20 to 29 at one time, and there was, and we all struggle, but community counseling was the last place that I thought of, and it's how do we focus group these, and how is the department going to focus group these individuals, these men, these people, to see what their needs are so that we are actually meeting their needs, because that's even over COVID, I lost a couple of my son's friends to suicide, and just recently my daughter lost a friend to suicide. We're losing our kids to suicide because of mental health, and we have a plan of a plan, and we've done lots of good things, and we're trying to reach out, and we're trying to work with Indigenous groups, and and it just feels like there's so many gaps that we're not being able to reach. And it kind of struck me when you said community counseling, develop programs. How many of those do we actually, that are community developed? And why are we not looking at those models for all of our, I think about some of our organizations that we have, the residential school counselors that we still have, and that funding has been continued, but we don't know for how long. But why are we not just working in partnership with our Indigenous governments and, and hiring counselors through them, maybe, and then going over, that would be my next question, is how are we working, like if we can't do the job description, why are we not working with Indigenous governments? Because I know, like, even when I was working with IRC, I had an elders meeting, and they defined what an elder was, so that way they could fall within that cultural support person as an elder, and they defined it. They got their elders and their youth together to define what an elder was, so that way there was actually a definition, and they can actually go through their residential school support as being paid as a support person, and be billing for this to be helping people, because some of our people go to elders. So those are thinking outside the box, and that's kind of where I see community counseling, and I don't see it being community counselors with master's degree coming from the University of so-and-so. I see it as a collaboration of community members, and I'm wondering how can we, when we're working with our Indigenous governments and together, how can we get there? And is the department even working there? Because these job descriptions we know are all overinflated, and we've seen this with the school counselors, where we had school counselors in the school for years, and then they didn't meet the requirements of the new position because they didn't have masters, but and some of them had to fight for to be equivalencies, and then that's the other thing, is, are you working with HR to make sure equivalencies are being looked at? Because so I guess there's a whole bunch of questions, and it just kind of went like this.
Thank you, Emily Summer. Mr. Kenneth?
I heard 4 things there. I want to give them back to you to make sure I understand. So one was about coordination of services. One was also about how do we reach the people that are actually not accessing our services. So you named men between the ages of 20 and 29. You talked about community development programs in the sense of how do we have community counselors at a community level. And then as a piece of that, I think you asked about the job descriptions. So I'll start, and my colleagues are going to need to jump in. So the coordination of services, without a doubt, is one of the issues within the one of the key issues that has been identified within the recommendations is how do we communicate what's available to our clients, and by far we need to do a better job of that, and not just our clients, those that are not our clients, and the families. So in some way, I'll combine those two areas around the hard-to-reach populations. This is an issue within health and social services across our system, and so I'll focus on addictions for today because that's why we're here. But folks won't access services if they don't know what's available to them. So in short, yes, we need to do a better job of this. We need to do a better job of this in different ways to make sure that people know what are the services that are available to them. And without a doubt, we have a variety of services that are available in a variety of ways, but making sure that people know what is available so that if you're having a conversation with someone, you can lead them in the right direction so that we can get that into the hands of the people that need to get them. So that's communities, that's our clients, existing clients, those are the public members as a whole. And so by far, it's figuring out how to target those hard-to-reach populations, and that's part of the work plan. That is part of the work that we need to do. We need to work with communities because they have the ideas, they know who the hard-to-reach people are. And so, in short, what I would say to that, it's not one size fits all. And so hence the reason we need to, and we're good at, I think from a GNWT perspective, in developing programs that are somewhat standardized and that are some ways structured in the ways that they should meet all clients. And we've done that. The core programs that we have in addictions and in, I will say, mental health are well done. But we need to now take this to the next step, and that is working with communities. That is working with, now we have these programs in place and these services available, but how do we tweak those to meet your region's needs or your community's needs? And so that's part of the engagement piece that we have planned within this work plan. That's the concrete part of that. The details of that are to be determined because we need to work with communities to determine what that may look like, and it might not be the same from one community to the next, but hopefully we can have some lessons learned and have some, we can translate that across communities and regions. I'm going to combine the other two, and that is the community development program in the sense of, and job descriptions. So I'll use the CYCC as an example. That program is going through what we would consider to be a turbocharged evaluation, and part of that is escalating that to and moving it up in time so that we can target the areas that we need to do and make changes quickly. And one of those is in job descriptions, and be able to look at our job descriptions, our policies, to make sure that we are targeting the right individuals for the right jobs, and having a combination of that across a continuum. There is a role for a master's prepared counselor versus one that's not at a master's level. And it's really determining where are those gaps and what are we not being successful in, because at CYCC, as an example, what we had before in schools versus what we have with CYCCs, there's potential that there's somewhere in the middle that we need to look at. So we are working with our ECE colleagues, of course, because that's a co-led initiative as an example, whereby we are looking to redesign that model for the next school year. And so that will include job descriptions. That will include looking at the opportunities for ensuring that we have the ability for Indigenous populations to screen into those, and community-based individuals to screen into those jobs. So those are just two examples. The one other thing I am going to share with you is the piece around community services. And so when I think about addictions, you know that we have the services and contracts with folks that are in the South. We have a number of programs that clients go to, but we also are working with our Indigenous partners as well to look at, because ideally, care closest to home is what works best for clients. So what would that look like at a regional and a community level, so that we can hear what, it's not just about services and sending people to the South. Maybe there are opportunities in communities and regions to provide addiction community-based services, that where people do not have to go south if that's not what they want to do. And so it's really strengthening CCCP, the community counseling program, is often a place for folks to come into to get out
of territory for addictions, but it's really about strengthening that piece of work at a community and a regional level to see what we can actually work together on to provide a different way of providing addiction services to clients who may not want to go south for treatment, as an example. So that was a lot of talk on my side of things. I hope I helped answer some of your questions, but I am going to pause for a moment again and see if my colleagues have anything they wish to add.
Mr. Jaworski?
Thank you, Mr. Chair. It was a really good series of questions because I think what it does is it highlights the complexity of this work, right? That these are not distinct pieces of work that the department is taking on. They are all connected, right? Like the recommendations are all connected, the work that we're going to have to undertake to achieve them, it's all connected. And, you know, I think Joanne's done a great job of outlining. I was making notes to myself as you were talking about things I would want to say, and I think there's no one answer to how we're going to tackle this. I think it's partly doing a better job at collecting our data and analyzing it to notice, because we do know that more younger people are accessing counseling now that we have CYCCs than they were before, but perhaps there is an age group where we are missing like a certain set of the population. And so I think through, you know, the engagement that we'll do, you know, around the questions that we want to ask around equitable access, I think through analyzing our data better, determining our outcomes, I think all of those activities will feed us more information about this, but also about other things, right? Which overall is going to help us do a better job. And, you know, I think Joanne mentioned also that I think we've often taken, as much as we say there's no one-size-fits-all, I think we've often taken a one-size-fits-all approach in our programs. And I think, you know, certainly I think the recognition that we need to take a much more flexible and really individualized approach with communities is an example of how our system is becoming more culturally safe. Like even just for my own self, you know, learning that that's how we have to work versus just engaging once and then implementing a program territory-wide, right? So I think there's lots of things that are happening. It doesn't happen overnight, but I think there's lots of good work. The only thing that I would add is that, you know, you mentioned about hiring local counselors, and so I know we've spoken about it in other forums, but I do just want to mention the Addictions Recovery and Aftercare Fund that is funding, that is targeted to Indigenous governments as priority to hire local counselors. So whether it was, you know, a graduate of the Deadly Wellness Warriors partnership with Rhodes Wellness College, or whether it's another local person, but that's exactly what that funding is intended to be. And that fund's not the only answer. We obviously need to do work on our job descriptions and our competencies and our qualifications, but I just wanted to highlight that because I think it is an important element that is available. So thank you.
Thank you. Ms. Kekri-Scott?
So I'll do that from the community wellness planning perspective, because we are sort of at a new phase, or trying to be, in that relationship. So when we started 10 years ago, really the number one priority was to make sure that the funding that was available from the federal government was getting out to every community that should be able to access that, because when we started in 2013, that was not the case. A third of the communities weren't getting anything at all. And then trying to make sure that we protected that space for communities to do what they wanted to do with it, and really to sort of let that be that autonomy. And so our approach has been very much that is community wellness, and then there's community health, and there's sort of a divide. At a community level, of course it's not. It's all integrated, and we know where we see the wellness plans in action. You know, there's grief workshops, and there's people coming in and talking about addictions and doing that community education and work with youth. Very often it's supplemented by other funding that's coming from different programs in the GNWT, but we also know that there's just government money. We're not necessarily at a community level paying attention to what's coming from the GNWT or what's coming from the federal government or any of that. It's just what's being offered. So we are trying to now sort of invite the opportunity. We're not requiring any communities to do that, but to be a bit more present in those conversations, and hoping that we've built that relationship base to have the trust to be invited in to have those real conversations. How can we be supporting the work that you're doing? Some people don't need us to be involved at all. They know exactly what they want to do, and they need us to give them the money and leave them alone. But that really does vary by community and by region. And there are also places where their allocation is enough to hire one wellness worker, and then their job is to find all the money to run all the programming and be able to do everything else. And so how can we help them to be able to do their full scope in their jobs and connect them to other communities so they're not trying to make it all up as they go. The other thing that I think, I really want to honor what you said, because I think it's true, and we see that in the wellness planning process. The young men are not there. That's not who's in the room when we're making those plans. That's not who comes to the programming necessarily. And so that's a challenge. But I think an opportunity also, if we have that base, we have 10 years of foundation to be able to say, we've shown what can be done really well, so let's see what can be done next, and to have different relationships around that. And that's really what we see as an opportunity in this next phase.
Thank you, Ms. Cacfrey-Scott. Any follow-up, Emily Semler?
I'm gonna follow up after my 4-question question. So going with, you know, and it kind of goes to my last question, I'll leave it at that, is what you said is, you know, community-based addiction treatment. You know, we know that the territories is crying for addiction treatment. Every time you turn around, that's what you hear. And then we've also heard past ministers say, well, we've done it before, it doesn't work. But we haven't done it in a community-based way. We've done it in one community, and we've done another one in another community. And it's very focused on those communities, and which is great for those communities, but it doesn't always fit territory-wide, right? And then it was modeled to not be so modeled around Indigenous people as well. So they were trying to smash a Southern model and say it's in a cultural model, and it wasn't working. So I know that the minister made comments about relooking at that issue publicly, and now that we've got this report saying, you know, we need to fix things, or we have work to do. Where's the department on that? Are we looking at plans or to see if we're going to work on this? Like, as a territory, I think our people, when we say we've got the highest addictions, you know, or if we're not the first, we're the second usually, you know, the amount of things that happen in our territory. And as a health provider, you know, when you're sitting in the emergency department, and majority of the people that are coming through the emergency are Indigenous, and a lot of them situations are related to alcohol. And so I think that's one thing, you know, when we say reconciliation, I think as a government, if we're not going to get the money, we're going to get the money from the feds. Like, we need to start looking at this as part of our plan to move forward and healing in the territory. And we need a territorial health treatment, how it looks, but it needs to be community, and it needs to be like very strong into the communities and to our small communities, to have those connections with our regional centers. And I think community counseling is laid that foundation, but how do we strengthen it so that way we have that, you know, the detox, the live-in treatment that people need. Thank you, Mr. Chair.
Thank you, Emily Semler. Ms. Chiquetto?
I believe you're asking me if the department is working on the potential for a territorial treatment facility. Is that what you're asking me?
Is that even an idea now that the minister has said that, you know, she's the one who opened that door, so.
It is always something that, you know, the approach to treatment for addictions is something that we are always looking at. This audit speaks to what can we do differently, what can we do better, and what can we improve upon. The first thing that I would note is that the audit did not speak to this. It did not make a recommendation for a territorial treatment facility. That doesn't mean we wouldn't necessarily look at that, but it did not come out of the audit. So from that perspective, I don't have an answer from the audit perspective. What I will say to you is that you're right, we've had treatment facilities in this jurisdiction before that were successful and unsuccessful for a variety of reasons. We have, as you know, we've talked about the surveys that we do to our client, that we would do with our clients and families, and hear from them around what has been successful for them, because success ultimately is that individual and family's definition, not ours. Those that go to treatment in the South, we've had, overall good success in the sense that that is something that those that do go, it is something that has worked for them in that experience. I think what we ultimately need is a variety of approaches to addictions. And would one facility in this territory achieve that? Likely not. But that's not necessarily my decision to make. I want to be clear on that. But I do want to say that it is something that we continue to look at. We know that we have our neighbors that are exploring one treatment facility. We know that even if we had one treatment facility in this jurisdiction, we would continue to need to send people south, because it can't be all things to all people. The conversations that we are having with community and Indigenous governments is really about what will work for the residents of this territory. And so when I talk about community and regional-based, community-based treatment, it's really about exploring that opportunity, because that is something other than seeing one-on-one counseling and having people go south for treatment. We don't have a mechanism whereby people can stay in territory for some form of treatment. So that is ultimately where we're currently at. Those are the recent conversations we are having with our Indigenous partners. It's also the information I would also share around our territorial alcohol strategy that is in its final stages. It's informing that work as well. But ultimately, at the end of the day, our goal is to provide our clients and families and residents with the options that are available to them for treatment. So that's a long answer, but I'll just pause for a moment again to see if anybody else has anything at the table that they wish to add.
Thank you for that, Deputy Minister. Any further questions from the committee? Emily Cleveland?
Yeah, thank you very much, Mr. Chair. My first question is, would the department be willing to commit to a youth-focused section of the work plan that would be coming back to committee? Thank you.
Thank you. Deputy Minister?
We are always open to, if you can, thank you, Mr. Chair. Thank you for the question. What I would say to that is, thank you. We would want to hear more about what that means. And so if it's really about focusing specifically on youth and what our approach will be around addictions, but we would like to hear back from committee about what your ideas are. So for sure, we would like to hear about that.
Thank you. Emily Cleveland?
Thank you very much, Mr. Chair. Absolutely. To further discuss this with my committee colleagues, for sure. And I mean, one sample of that is, in order for a youth to access funding for treatment services, the funding comes from Child and Family Services. And when we're talking about cultural safety, that's a barrier right there. And so I think that there's additional conversations to be had about youth and how the department plans to communicate with youth and provide paths to services. My second question, and just in relation to what MLA Semler was talking about and the response referencing the Indigenous Counseling Program, where we had great success in the territory with graduates this past year. If Indigenous counselors are being funded through an annual funding arrangement, my concern goes to, does that mean that these people are on term year-to-year positions that are funded through the Indigenous government? Whereas, so there's somebody in a community with, say, 2 years of experience having finished their program, who's been in the community maybe for those 2 years, that has job stability in an indeterminate GNWT position, and then the second counselor in the community is a graduate of the Indigenous Counseling Program with no job stability and is operating on a year-to-year term, less benefits, no pension probably, and that person, if they have a lifetime of experience really to be able to offer. and if they have the trust of community members, and then their potential to do great work far exceeds somebody who doesn't have the trust of community members. And so my next question is, will the department then commit to also including a space for Indigenous counseling program graduates in their work plan as well, given the value that, especially we hear in this room from my colleagues, that is placed by the community on these people who have done this work? Thank you.
Thank you, Emily Cleveland. Deputy Minister.
Thank you. What I can say is this fits into the pieces of the policy and the job description work that we need to do. And so really it's about ensuring that we review that process and together with our HR colleagues to ensure that we have a mechanism to hire the most qualified, but not necessarily, when I say qualified, meaning masters, but the appropriate people into those positions. And so if they are those graduates, that would be our goal. Our goal is to have Northerners in these jobs as appropriate, right? And so it's really about going through that HR process. It's about whatever the policy change that needs to occur, whatever the job description changes need to occur, and to ensure that we are providing safe, competent care to clients and their families. So I'm going to pause again to see if anybody has anything to add.
Ms. Cackfrey-Scott.
I would just add as an available spending, not everyone wants to work for the GNWT, and so that work is all really important for the communities. If they wanted the opportunity to hire those graduates in their community, that is a reasonable use of community wellness funding, which does go to communities on that flexible 5-year block funding agreement. So there's carryover and there's no question of whether the funding is coming in the following year. It is a finite envelope, so whether or not that's where it gets allocated or if it's already been used to hire someone else in the community is of course another question, but there is that as an available flexible funding source.
Thank you for that. Any further questions from committee? Emily Cleveland.
Thank you very much, Mr. Chair. Mr. Chair, my next question is in regards to, I understand from the presentation and from previous conversations with the department that there is a cultural safety unit within the Department of Health and Social Services, and as part of their cultural safety action plan, they had a goal of, in 2020, of developing an equity lens that would be applied to programs and services. I'm wondering, Mr. Chair, if the department can speak to whether or not this work has been done, and further to that, how the department plans to take kind of the definition of cultural safety and operationalize it, so that this idea that comes from headquarters of how stuff should flow down to frontline has a mechanism to get there. Thank you.
Thank you, Emily Cleveland. Mr. Caddo.
Thank you. I'm going to actually have Ms. Cackfrey-Scott answer that question.
Cackfrey-Scott.
So excited to answer this question. So there are several pieces in that. On the equity piece specifically, there is, as detailed in the work plan, a draft health equity assessment tool that we have developed exactly enough to know that it's going to be really complicated to implement. So we're now talking about how we test that in areas where we can sort of work through the kinks but feel like it's high yield. And so that's what we're looking to do over the course of the rest of this year, and then to continue to have that be a conversation. Part of that needs to be a lens on where do we know exactly enough to know that we need to go out and talk to other people in order to understand what the gaps or what the issues are there. It's a tool to help us to know where our blind spots are. So that's work that's continuing. On the cultural safety and anti-racism side of things, I heard a question about the definition and then how we're doing that across the system. So we have defined in the Northwest Territories cultural safety as an outcome where Indigenous peoples feel safe and respected, free of racism and discrimination when accessing health and social services. And because it's an outcome, that means that it's not something that we as a system can do. We can't say that we offer culturally safe services. We can't say that we, as at an individual level, provide those. We can receive feedback from people when we have managed that or not. And so the question is then, what is the responsibility of the system as the action and of the people who work here? And so when we offer that 2-day training, and this is why it's morphed over time. Originally, years back, we were talking about cultural competency training, then we were talking about cultural safety training. Now we're talking about cultural safety and anti-racism training, because anti-racism is that action framework. That is what we can do at individual practice and at system practice in order to be moving towards those outcomes that we want to see from the perspective of Indigenous patients and clients. Our action plan has 4 areas, and we know that this is not, we can't say cultural safety is achieved because we did something different at the front line or because we did something in the minister's office. It needs to be a whole system effort. And so we have those 4 big buckets. We have the organizational culture of cultural safety that we're working towards building. We have strengthening staff capacity for cultural safety. We have bringing Indigenous knowledge and healing into the system or incorporating it into the system. That's one of the sensitivities. It's the government of the Northwest Territories. It's not necessarily ours to offer, but it is certainly ours to respect and incorporate where appropriate. And then to be enhancing patient and client experience. So the cultural safety and anti-racism unit, which grew into being that when we did the reorganization back at the beginning of last year and created community culture and innovation. We're continuing to adjust in the system. So you would have heard me introduced as Assistant Deputy Minister, Corporate Services and Cultural Safety. That's new. That's not a position that has existed before. We've brought the cultural safety into the ADM portfolio. We're also doing another reorganization of community culture and innovation and actually pulling the cultural safety and anti-racism team out and making a standalone division so that we'll have that expertise and voice at the senior management table and continue to enhance their ability to have that connection across the system, working directly with 3 health authorities. We have some processes in place to make sure that we've got the connection to, our strategic documents and things that we're doing there so that we have that cultural safety and anti-racism lens applied as much as possible across the system, recognizing it is still a small team, but we're really trying to build that capacity both within that specialized unit and also through ongoing learning and development for staff across the system, because it's something that people really want to be able to do and are being very vocal about where they need learning support or resources or tools or things like that in order to be able to change practice.
Thank you, Ms. Scott. Any follow-up on Rylund?
Thank you very much, Mr. Chair. As we're talking about this and I'm thinking about this and thinking about the conversation I had this morning, what's happening in our territory right now, when we start thinking about the anticipated timelines for the work plan, and then and then from there the outcomes, it makes me nervous that, and I know nothing happens at the flip of a switch, and I know that we often ask for it to happen at the flip of a switch, so I want to acknowledge that. But I'm wondering if there's room to turn that idea as well, while it's happening from the top down, to turn it on its head and create a process whereby your the department's frontline staff are able to themselves have a mechanism to identify barriers in policies and to be able to create those changes in real time. And so, when I gave the example earlier of child and family services for some people, and no judgment in that, but there's a history there, right? And that being a barrier for some people. Is there a mechanism that can be put in place, say, where the unit that deals with adult services is able to, if that's a barrier, people can access that. Say somebody wants to access a different treatment center that's not in the RFP list of pre-approved treatment centers, that they're able to work through that process somehow. Because what I find right now is only people who are willing to come to their MLA and fight through that process get the green light. And not everybody is willing and capable of going through that fight because they're using all their fight to get out of bed every morning. Thank you.
Thank you, Emily Cleveland. Deputy Minister?
Thank you. I don't think you were asking that question specifically around cultural safety. Is that correct? It was overall around addictions. No worries. I just want to make sure. Thank you. And, ideally, that's how our system should be working. And so to answer your question, yes, ideally, we should be having, these barriers need to be identified at all levels, and we need to be responsive to them. So in any work plan that I think we would ever produce, it's not just about those timelines. It's about what happens along that journey and how we can make those changes along the way. So it's not just about saying, although we're going to do something in 23, 24, if there's improvements along the way, of course, we would implement those and make those changes. And that at the end of the day, the target is to ensure that by 23, 24, they're completed. So yes, we need to, I think what I'm hearing from you is have a better way for staff to identify the barriers that do exist. So I'm hearing that. And of course, that's why we're here today, is to make change and make improvements. So thank you for that.
Thank you, Deputy Minister. Are there any further questions from committee? Seeing none, on behalf of committee, we would like to thank you for coming here to present today and all of your work on the response to the audit. We will follow up in writing, and that concludes our public portion of our broadcast.